Students, the purpose of the week 5 video lecture is to review the steps of completing the second steps. Doesn't make sense, doesn't it? How about this? The purpose of this video is to review the AA in the Marie process. Last time we did the methods section, and we added an additional step in here called conflict of interest, and so you've had some practice doing those. This week we will be looking at the section, assignment, so selecting people and putting them in control and study group, and the assessment group. What did they choose to look at for an outcome? So would you have these documents in front of you before you watch this video? And I'm going to apologize in advance. I'm doing this video from my home, and so if there's dogs barking, they're probably just protecting us from some very bad people that might come to our home sometime. You never know. I bet some of you have dogs who protect you viciously like that. I have disconnected the landline phone, so hopefully it's not going to bother us, but if we have some of those distractions, I apologize in advance. So would you have these documents, and you can find them in your assignment folder. From the week 4 assignment folder, will you have a copy of those Marie questions? And I think you probably already printed them out, but if you didn't, that's where I'm getting the questions people in the group similar. Oh crud, I hope I didn't just turn something off. Okay, I'm hoping that's on. I pushed a button accidentally. Then you want to look at those yourself, or if they reported p-values the normal way, pretend this column's not here. I would just look at, hey, they already did a statistical significance assessment to see if the two groups were similar or different. And if there's a statistical difference, the p-value would be less than 0.5. Now, what I want to have in these two groups is no statistical significance. So it actually would be a bad thing if there's a difference between the treatment and control group, because that could affect the outcome. So you could agree with the authors and say, hey, I think the numbers are pretty similar. What I'd probably expect you to do is look through these, and if they're really what seems like fairly similar, let it go. But if you have an example where you say, I think that could make a big difference for this P to F ratio, then you just write that down as part of your answer, okay, for the study you're to be evaluating. Okay. So I really like when the authors have done it nicely, where they have treatment group, control group, p-values, where they compared the treatment and the control groups, and I just have to look down this column to see if anything is statistically significant. And what the authors are hoping happens is, for baseline characteristics, we don't want there to be a statistically significant difference. We'd like those p-values to be greater than 0.05, where in the rest of the study we may want things to be statistically significant. That's a mouthful, isn't it? Okay, if you have your Marie document in front of you, I'm still answering questions in the process, the number 1 step process of the assignment section. Next it says randomization is one of the steps of a randomized control trial. That's kind of makes sense, doesn't it? And so how did they specifically assign the group? So this is specifically, how did they randomize? And so I look up here, and I've highlighted these in my document. All right, and it is, I have to find it. Apologize if I'm making you dizzy. Here we go. Eligible patients were randomly assigned in a 1-to-1 ratio. So for every one person that went in the treatment group, another person went in the control group. And randomization was performed in undisclosed block sizes of 2 and 4. So they are basically saying that they did it in blocks, that for every 2 participants that went into the treatment group, the next 2 in that block would go into the control group. They did that in blocks of 2 and 4, so it would kind of alternate. So by doing blocks, they assured that the most that you could have as far as differences in number between the treatment and control group is a value of 4. That's the highest. So they're doing this in blocks of 2 and 4 in a 1-to-1 ratio. So 2 to 2 and 4 to 4. So I would just undisclosed, and they say they used a central web-based randomization system, and it was stratified according to centers. So each different clinical site would phone in maybe, or log in, it sounds like on here, because it was web-based. They'd log in on their computer, they'd look at, okay, what set of numbers am I at right now? And it may be that even numbers go in one group and odd numbers go in another one, but it was basically a computer that was assigning participants based on blocks, and it would do those randomly. So the way I'd answer that question is they used a web-based program that generated the randomization based on a 1-to-1 ratio in blocks of 2 and 4. Okay, next we move to the question of, I guess the reason that we ask that question when we're evaluating the study is that would be one way to add bias to the study. If I were an unethical researcher, I might be tempted just to, when I had a really sick patient, say, oh, they qualified to go into the control group, because I want the control group to look like they had less of an effect than the treatment group. So it's to keep people kind of ethical and honest. How did you really do random assignment? It could be as simple as flipping a coin. And I think you could see the problem with that. What if we just say, if you flip heads, they go in the treatment group. If you flip tails, they go in the control group. What if, on the rare chance we flipped all heads? So do you see that it wouldn't work very well, would it? And that's why usually we have computer-generated numbers, or we have computer-generated values that are put in sealed envelopes or accessed by a computer. You open them up, and then remember that the difference of adding the second level of doing it in blocks, and sometimes it will say block permutation or something similar like that. Then they did it so that the most that you could have different between the treatment and control groups is maybe 2 people or 4 people, like our study did, because they're doing maybe the next block of 3 people will all go in the treatment group. The next block of control will all go in the or the next block of people will all go in the control group. But I don't get to choose which group they go into. A computer did that for me. All right, the next piece is we move to confounding variables. And I should have told you which page you could find this information. I'm sorry. So I found it on page 3, and it continued from page 2. So continued from page 2 to page 3. I'm reading, because I have a notation of page 7, and I don't know why I put that there. Okay. Next I'm moving to question 2 under the assignment section, and it deals with confounding variables. Oh, you know what? That's what I did. Will you forgive me that? I'm talking about all these are the treatment groups, are the patients in the group similars, and we did that. Oh no, I'm sorry. Boy, can you tell me I'm running on just not very much sleep right now. All the things I just spoke about correctly go under the process section. Now we move to confounding variables. Confounding variables, you have definitions of these in your assignment document, so you should have a pretty good feel for that is. And if you didn't read all your definitions, you probably want to stop this video and go back, because I really explain randomization. I explain confounding variables. So with this one, I could pretty much go to that baseline characteristics table for just a little bit, because these are the things that the authors thought could be a difference between the 2 groups that could affect the outcome. And so with confounding variables, we're looking at, are there things that you think could affect the outcomes of a study that deals with patients who have a condition called adult respiratory distress syndrome, and they're either treated with normal ventilation using a conventional ventilator, or they're ventilated with high frequency ventilation. So I bet almost all of you, I know that we have a lot of respiratory therapists, and I did not just pick this article because there are a lot of respiratory therapists in this class. I pick articles that are really in the front of medicine right now and being talked at a lot. And this is one of those, because we figured high frequency ventilation would be helpful to patient, and in fact there have been some studies published that said that. This study is getting talked about because it found that high frequency ventilation was actually harmful to a group. It led to higher mortality. So now those of us that use high frequency ventilation are left trying to sort out which one is the truth. And that's where that critical analysis comes in, is can we look at the study and decide it was done very well and we should trust the data, or was it done poorly? Are there things that should have been improved upon? Okay, so one of those things then, when we're going to ventilate patients, how similar or how different are they? And now we're looking at, what did they choose to look at? So I will explain just a few of these to you. It makes sense that they would look at how critically ill they were, and it's a common way to do that is to use the Apache score. It would make sense that you look at a person's oxygen level and their carbon dioxide level to see how critically ill they are. And it would make sense that if someone started with a higher carbon dioxide level or a lower oxygen level, they might have a higher chance of dying if they were given mechanical ventilation. So that's the question we're kind of looking at here, is what were the factors, if you designed this study, what are the factors you think could cause death in someone receiving mechanical ventilation? So I think it could be that they get an infection in their bloodstream, which is sepsis. I think if they had pneumonia instead of just ARDS? What if they had aspirated something? What if they'd had trauma? So these are risk factors for ARDS. They're telling us how sick were those patients that had ARDS. What if we had a whole bunch of septic patients in one group? They're much more likely to die with things like kidney failure. So the question here asks you, as you look at the study, what are things that could affect mortality, which was what their outcome, in the treatment group and the control group, and do you think the authors did a good job of identifying and controlling those? So inotropes or vasopressors are medications given to patients who have bad blood pressures. So could that make a difference in who dies? Yeah, because if you don't have a good blood pressure, your organs don't get oxygen to them, and that could cause you to die. So we're looking at this, and I realize that some of you, if you're not clinically based, you're coming at this from a little bit of a disadvantage, but I want you to stretch yourselves a little bit and try and think of something. On this list anywhere, do you think it could make a difference if you were a smoker and we had to put you on a ventilator to keep you alive, and we're looking at whether you die? Do you think it could make a difference if you had a bunch of non-smokers in one group and a bunch of smokers in another one? So if I look at this list, does it look like they controlled for people who were smokers? And I don't see that. So I might put that down, because the question is, can you think of anything else that could affect the outcome of the study, that can influence the results of this, that the authors didn't identify or control for? And I don't see that they put smoking on here. I didn't see that they put some sort of evaluation of how bad their x-ray was. So I've had ARDS patients, and we really usually look at their severity based on this P to F ratio, but I've had people whose x-rays can look horrible and people whose x-rays can look really good. It might make a difference on who runs the ventilator. How much experience do you have with the high frequency? With high frequency ventilation, the other reason I mentioned chest x-ray is your x-ray and your diaphragm placement are key. And so they don't tell you diaphragm placement on x-ray anywhere here. And so those are some things that the authors, I feel they should have controlled for. Those are just a couple I quickly came up with, and I'll bet you could think of other ones as you looked at this list. That's what I'm asking you to do with the other article, that you're more familiar with the content, is what could cause blood clots to form, and did the authors look at those and control for those? Were there things that you know increases the risk of blood clots, or something that it doesn't seem like they controlled for? Like they didn't account for, have they traveled more than X number of miles, or have they sat for, do they sit at a desk all the time? Because sitting or being sedentary or stationary increases your risk of blood clots. Okay, so the next thing I'm going to do is move to question 3. Masking or blinding, and this is under the assignment process. So when they assign people, did the patients know which group they were being put in? Did the researchers know which group the patients were being put in? And so an easy way to do this might be to use that search tool where I showed you last time. Either over here you'll have the pair of binoculars, or if you have this kind of Adobe Acrobat, you do edit and then find, and I could say blinding. And this is not poking their eyes out, right? If you did your reading of your assignment, you know what we're looking for here. Or masking, and I didn't find either of those words. Now that's kind of cheating, because I really should read the article. And I'd read the article and I thought, you know what, I don't really remember them saying much about that. If they're really proud of it, remember, they should put it right there for you to see, and it makes sense it would be in the methods section. It's typically towards the area where they did the power of the study. So I looked in that piece, and this is what I found. I found it here with statistical analysis, and that doesn't make sense, but it's here with the statistical information. So you might have to hunt a little bit. What you're looking for is, do the patients know which treatment they're receiving? And it would be kind of hard in this case. It's not like you're giving a pill and you could make a fake pill look like the real pill. The therapists who are running the ventilators, the respiratory therapists, would know which group is the treatment group and the control group. The physicians that were taking care of the patients would know that. You can't just put up a screen and hide the ventilator because it makes a specific sound. So they come down here and they say, the investigators reviewed the feasibility. This is the piece I need. But they didn't know the clinical outcomes. So the people who looked at the data didn't know who died or who lived. And the data monitoring committee that looked at the data, that looked at the outcome, the people who died, didn't know which group they were assigned to. And so it may be that when the people look at the data, if they don't know who was assigned to the treatment group and control group, then they can't skew the data. So the message would be, don't have the same doctors or respiratory therapists that are taking care of the patients doing the data analysis. And it does look like they did some effort to screen the people who are evaluating the data when they were collected from the research study, did not know which group the patients were assigned to. But even there, the authors don't do a very good job of clearly stating that. So again, a good study will usually have masking or blinding, so I might put that. It was hard for me to find whether they were, because I know about those ventilators. I know it would be hard for them to, definitely the therapists would know, the doctors would know. The patients are going to know. It's not that they could do something about it. The patients are probably not going to do a survey that says, yes, I felt like I died. The patients are either going to die or they're not going to die, and it's not something the patients can do to control the difference. The therapists or doctors, on the other hand, if I really wanted the people in the treatment group to do really well, I might take better care of them, either intentionally or unintentionally. So we've completed the questions in the assignment section, and now we go to the assessment section. And in the assessment section, I want you to answer this question. 1, is the measure of outcomes or endpoints in the study appropriate? And so you're going to look for, you're going to remember back to your hypothesis of this study. And we learned last week that we could find that really easily in the abstract, or we could find it usually as the last sentence in that introductory section. And these authors were looking at whether patients who are ventilated with normal conventional ventilation or high frequency ventilation had a higher death rate. So here is again the quick and dirty answer. Their primary outcome was rate of in-hospital death from any cause. That means kidneys, their heart just stopped, so the electrical pattern of their heart, not just their respiratory system, but did they die after receiving, if they were in the treatment group, if they were in high frequency ventilation, did they die? If they were receiving conventional ventilation, did they die? When I come down here, I find more specific information about that, and it will usually be not in the statistical section. It will usually be in methods again, but this these authors chose to put it in the statistical section. The primary outcome was in-hospital mortality, with the outcome compared between the two groups stratified according to center. So they also looked at, were they in an ICU in Canada or an ICU in the Saudi Arabia, or were they in ICU? Because you think that could make a difference, huh? And they looked at whether the death occurred as, did we withdraw life support and the patient died, or did they have some sort of cardiac or respiratory event where they died on the ventilator, not because we removed it. So with that question, you're just listing what is the outcome that the authors chose to measure. These authors chose to measure death. And I can argue, based on what I know about mechanical ventilation, I don't think they should have just looked at death as an outcome. I think that could have maybe been one outcome, but I wish they would have looked at, pulmonary function in 5 years after receiving that kind of ventilation. Or maybe they could have looked at number of ventilator days. That's a common one. How long they stayed in a hospital. These authors chose to use death. The nice thing about it is when we go to the second question under the assessment section, it says, is the measurement of outcomes an accurate and precise measure of the phenomenon the investigators seek to assess? So, is it accurate and precise? That's one question here. Can I accurately assess whether the patient died or not? Well, hopefully they either died or they didn't. And can I precisely assess that? Hopefully I can do the same thing. Now I have to say, I know that I can measure death accurately and precisely, but is it a really good measure of what the authors wanted to look at? Well, they said they wanted to look at, I go back to their hypothesis, they wanted to look at patients who were intubated and received either conventional ventilation or high frequency ventilation, which group had the higher death rate? That's what they're going to look at. It seems like they did a good job of matching their outcome. They did pick an outcome that can be accurately and precisely evaluated. In that same section, if you read on your Marie document, there's a piece where it talks about reporting bias and that it's not likely to occur in a randomized controlled trial. What if your outcome is the number of people who buy Corn Pops cereal? That's the kind I happen to have in my cupboard right now because it's in a yellow box as opposed to a red box. And not red box movie box, but a red colored box. And they would do some sort of study where maybe they look at people shopping and then you go home and you complete a survey, and because the survey was done maybe a week after I did the shopping, I don't quite recall things correctly. That's an example of recall bias when you're filling out surveys. When someone calls you and says, how many times have you eaten at Taco Bell within the last month? I hope I'm not the only one who gets those surveys all the time. I'm just the one silly enough to answer them. Now I'm going to go to question 3, and this is our final question. I bet you're happy. Complete and unaffected by observation. Is the follow-up of participants nearly 100% complete? Now, follow-up, you think it would mean, do they call people on the phone? Did they go out 3 years? So in this section, you should not put, this study only ran for 40 days. You should not put information like that. That's not what we're talking about. Follow-up is not a length of time. Follow-up is really this question. Did the same number of people who started this study end the study? And again, I'm going to go back to this table you looked at last week, and it's the one that showed who met inclusion criteria, who ended up enrolled in the treatment group and the control group. And now I come down here and I say, okay, 273 started the study. I ended up, they had 1 who left, and we're answering in that question, if there were people who left, did the authors tell you clearly where they left to? Not they moved states. It's why didn't they finish the study? Why did these 3 people not finish the study? So they withdrew their consent. This one withdrew consent. So they were terminated from the study. That makes sense. Now there's a thing, and with the randomization it came in, intent to treat is one thing we'll evaluate. They did intent to treat. So you can't just look down here and say 275 people started the study, 270 ended it, or 275 ended it. Look what they're telling you. They're telling you that we did use a number of 275 and 273 to do all our data. We did on intent to treat basis. It was intended that these people would receive conventional ventilation. It was intended that these people would receive high frequency ventilation. But sometimes people get the wrong therapy. What if I have a doctor who was supposed to get a patient who was supposed to get conventional ventilation, and their doctor is such a believer in high frequency that they say, no, I'm going to have this patient get high frequency. And if they were in a study, it may be, if we do intent to treat, that person still gets put, even if they got high frequency ventilation, they still get put in the group they were assigned to start the study. But the author should clarify that somewhere. So these authors are telling you these many people started the study, 275. There were not even really 275 who started the study, because they say some of these people died before they even got to that point. So how many people? Well, they say it looks like maybe only 270 really started the study. It does look like the author clearly told me how come those people were withdrawn, or how come their data was not included in the calculations. That's the question you're doing. And again, it's to make sure that the authors are ethical and straightforward with their information. If I wanted one group to look better than the other group, I might take 6 patients who looked like really bad patients and throw them out of my oscillation study. maybe I had 6 people who did really severely bad, and I just say, you know what, if I took those people out, my data would look so much better. So I would just take them out, and I would say 275 started the group, 216, 6 people, 7 people finished the group, and 66 finished the group, and I wouldn't tell you anything about where those 6 people went to, what I did with them. Okay, so I hope this video has helped you. And the nice thing about it, you can go back over it again and again. If you need something to put you asleep, you can listen to my voice and let me sing you to sleep. Thank you for your attention and watching this video. I'll try and keep these as short as possible. It does seem like I've rambled with this one.